25 years old male. I work as a doctor in Tawam Hospital.
Okay, so what brings you here? Like, what brings you to the hospital today?
Well, since yesterday, I start to have this dull pain in my upper abdomen. It started like at 5 p.m., but now I feel it more in my right lower side of the abdomen.
Okay, so it started yesterday and it's in your lower right side.
Yeah.
Okay, so tell me more about the pain. Did it start after, for example, a specific thing, or did it start suddenly?
No, it started suddenly. At first, it was mild pain. I was tolerating it, but then it increases, and I feel it now more in the right lower side of my tummy. I tried to take paracetamol. It improved the pain at first, but then came back, and I was worried. That's why I came today to the hospital.
Okay, and has it been continuous since yesterday, or is it intermittent?
No, it's continuous.
Okay, so are there any associated symptoms with it that you felt, for example, vomiting, nausea, diarrhea, or anything?
Well, I felt nauseated yesterday evening, and I vomited once, like couple of hours after the pain. That's it. I don't have any constipation or diarrhea. I felt feverish, but I didn't measure the temperature at home.
Okay, and can I ask about the vomitus? What was it exactly? Was it food? What was it?
Yeah, it was yellowish in color with some food content.
Okay. Um, is there anything that made the pain worse?
Not exactly, no.
And is there anything other than the paracetamol that you noticed that made the pain, for example, less?
No, only the paracetamol improved it for a few hours, but then it came back.
Okay. I'll just now ask you quickly about symptoms in general and tell me if you had them or not. So, did you have loss of appetite yesterday, since yesterday till today?
Yeah, I think so. I don't feel like I want to eat anything.
Okay, and you told me that you also felt feverish, right?
Yeah.
Okay. Have you had any, for example, palpitations or anything?
No.
What about chest pain or problems in breathing?
No.
Sweating?
No.
Did you have any problems like in يعني urinating or in the urine frequency, for example?
No, nothing. Nothing such.
Okay, so nothing but feverish and loss of appetite, right?
Yeah, and I vomited once too.
Yeah, vomiting and nausea as well.
Yeah.
Okay. Okay, so for me, that's what I'm thinking about the history for now.
But you have to proceed with the history. You complete your history with the past medical, past
Ah,
surgical.
okay, yeah, okay. Zain, okay. I thought you just wanted the history of presenting illness. Okay. Okay, tell me, do you have any chronic conditions?
No, nothing.
Have you been hospitalized before?
No, this is the first time I present to the hospital.
Okay. Are there any medications or any supplements that you take regularly?
No, just some painkillers when I have headaches, but that's it.
Okay. Do you have any allergies?
No.
Okay. And you told me you've never been hospitalized before and you've never had surgeries as well, right?
Yeah.
Okay. Is there any family history of any chronic conditions that run in the family?
My father and mother has diabetes and hypertension.
Okay. And are there any other diseases in the family or only these
No,
two?
no, only diabetes and hypertension.
Okay, let's see now. I'm just gonna ask you about like social questions, if you don't mind. So you told me that you're a medical resident.
Yeah.
Can I ask about your diet? Like, what do you eat usually?
Usually I eat from outside. I don't have a lot of time to cook at home.
Okay, and how about like physical activity? Do you exercise regularly or?
No, I don't exercise regularly.
All right. Do you smoke?
No,
Do you consume alcohol or illicit drugs?
no.
Okay. Okay,
So
now I think. Mm,
thank you, Rauda, for the history.
okay.
So now this is a summary of the case. The patient is a 25-year-old male presented to the ER with 1-day history of periumbilical pain that's shifted to the right lower quadrant, and he described the pain as constant, sharp. Didn't ask about the severity. Improved with analgesia, but came back associated with vomiting and loss of appetite, which we can describe it in medical terms as anorexia.
Mm.
He has normal bowel habits and no urinary complaints, and negative past medical and surgical history. So now, from the history itself, what do you think we are going in which direction?
I'm thinking this is a classical presentation of appendicitis because it usually starts periumbilical and then it goes to the right lower quadrant.
Exactly. So now we will proceed with the physical examination and then we will discuss the case. So tell me, Rauda, what you want to do? How do you examine this case?
Okay, so from what I know, there are some specific clinical signs for appendicitis. So I'll do, of course, the general
Exactly.
abdominal examination, اللي هو inspection, palpation, and auscultation. But since I'm thinking about appendicitis, I would like to check for McBurney's point tenderness, if there is guarding or rigidity, and then I'll look for rebound tenderness as well. There are also specific signs, such as the Rovsing and the Soos sign.
Okay, but start from the beginning. Now, imagine yourself, you are going to the ER, you were called by an ER physician that there is a suspected case of appendicitis, and you
Okay.
went to the room. Start by general inspection of the
Yeah.
patient.
Yeah.
Like,
Okay.
what do you
Yeah.
suspect the patient will be? Will-
Usually,
Yeah,
when they have appendicitis, they're in severe pain, so the patient is usually in distress.
exactly. The
Yes.
patient will be in pain.
Yes.
Then, after your general inspection of the patient, what do you want to know before you examine the abdomen?
I want to know where the location of the pain exactly, so that would be the last place that I palpate for the patient.
Yeah, sure. But like go systemic, like you started by general inspection, then
Okay.
we'll examine the vitals of the
Okay.
patient. You want
Yes.
to know, are you dealing with a stable patient or unstable patient? Because
Yeah.
it will make a huge difference in your management.
Yeah.
Now, if I'm going to give you the vitals, the patient has a temperature of 38, a heart rate of 109, a blood pressure of 125 over 67, and normal oxygen saturation. So what's the abnormality in these vitals?
You told me the temperature is, okay, it's here,
38.
38. The patient is tachycardic.
Okay.
Uh, yeah, so here we have fever and tachycardia.
So, but the patient is vitally stable. We can consider the patient as stable vitally, but he is febrile
Yeah.
and he's tachycardic. This tachycardia most likely either because of the fever or also can be like explained by the patient is in pain. He will be tachycardic if the patient is in pain.
Yes.
So now we'll proceed with our abdominal exam. How you will examine such a case.
Okay, so first I'll start with inspecting the abdomen for any masses or any asymmetry or any, for example, skin discoloration or rashes. And then I'll start with auscultation. I'll listen for the vowel sounds, if they're normal, if they're high pitched. And then I'll auscultate for bruits. And then I'll go with percussion. to see if it's resonant or dull on percussion, and then I'll end up with the superficial palpation and then deep palpation.
Okay. So we'll start now with inspection. You are inspecting the abdomen. Other than the skin rashes, you look also for scars of previous operation.
Yes.
This will give you an idea. Did he do anything in the abdomen or no?
Okay.
You'll look for the hernias. You'll ask him also to cough, and you'll look for any bulge in the
Yeah.
umbilicus, in the groin. For example, if I'm giving you similar scenario, patient comes with right lower quadrant pain, nausea, vomiting, and he didn't give you a history of a bulge in the groin. But when you examine, there is a bulge in the groin. So what do you think? Maybe the patient is having incarcerated inguinal hernia.
Yes. Yes.
Okay, and it's important to rule out hernia on examination of lower abdominal pain. Now, this is for inspection. We'll go with auscultation. If I give you
Dr. Lutfi, I appreciate you saying that because that is, you cannot state that enough. The problem with a lot of our junior colleagues and medical students is a lot of times you feel uncomfortable asking a patient to bring down their pants lower and to really inspect the groins. A lot of people might think that just palpating the right lower quadrant is adequate. I've had one patient taken to the operating room with severe right lower quadrant pain, and then when I got to the operating room, I haven't seen the patient yet. The resident saw the patient. I exposed the patient, and there it was, a bulge in the right lower quadrant with incarcerated bowel. So that should never, ever, ever happen. That's why do not feel shy or embarrassed to uncover the patient, request respectfully. And if they refuse, find a female physician that will examine the patient, whatever it takes, inspect the groins. Okay. Thank you, Dr. Doctor. Please continue.
Sure. Now we'll start with the auscultation.
Okay.
Usually for me, I like to start with the palpation, but it's okay.
Okay.
You can start with the auscultation too. If I tell you that there is absent bowel sounds in the right lower quadrant, what will you think?
Either a really severe obstruction or ischemia because that's abnormal. But
Yeah.
usually, yeah, okay. Usually with obstruction, it would be high pitched more.
Yes, exactly. With obstruction, it will be hyper-pitched bowel sounds. But if I'm telling you that there is absent bowel sounds, either there is ischemia, which is unlikely to be in this case, a
Yes.
25 years old young
Yes.
male with no past medical history, and there is no like bleeding per rectum or anything that can like precipitate the patient to develop ischemia, or there is some paralytic ileus,
Yes.
like the bowel is not moving.
Yes.
So if I'm telling you that there is a paralytic ileus in a case of appendicitis, does it make sense or no? Like, can we have paralytic ileus in appendicitis?
I'm not sure صراحة.
Okay, let me explain to
The
you.
inflammation,
Hmm?
maybe because of the inflammation.
Exactly. If there is inflamed appendix, the bowel will not be like in its normal function. It will not be doing the normal peristalsis. And
Yes.
that's why you might not hear the bowel sounds in the right lower quadrant. And this is a sign of acute appendicitis too, absent of bowel sounds.
Yeah.
So now we'll proceed with the percussion. If I'm telling you that there's right lower quadrant percussion tenderness, what will this signifies?
That there's an ongoing inflammation. That's why there is tenderness.
Exactly. Not only inflammation. If I percuss in the right lower quadrant and the patient feels pain, it means that also there is some parietal peritoneal irritation.
Yes.
Okay, so there's some elements of peritonitis too. Okay, so now let's proceed with the palpation. We will do the light palpation and then the deep palpation, starting from opposite to the site of the pain. Now the
Yeah.
patient is having tenderness in the right lower quadrant. So is this also a sign of appendicitis?
Yes.
Of course.
Yeah.
Okay. The other findings that we elicit on this examination, in the scenario, it's written that when palpating in the left lower quadrant, he reports pain in the right lower quadrant. What do we call this sign?
This is the Rovsing sign.
Exactly.
Yes.
And do you know why it happens?
Um, I'm not sure. Maybe it would, as you said, because of the peritoneal element, it would elicit pain on the opposite side.
Exactly. So the appendix is inflamed, and when it touches the peritoneum, it will irritate the peritoneum, and it will give us localized pain at the site of parietal peritoneum. So this
Mhm.
is the basis of all the maneuvers or all these signs that we are going to do in the physical exam. For
Yeah.
example, if we do the Rovsing sign, if we touch in the left side in the abdomen, this will also cause the peritoneum to be close to the appendix on the right side.
Yes.
So once the peritoneum touches the appendix, it will cause the pain on the right side, not on the left side.
Yes.
Also, if we want to proceed with other special tests, you
Yeah.
mentioned the obturator and the ZOAS, as I
Yes.
remember.
Yes. Yes.
So what is the ZOAS sign?
Usually when this is when the right lower quadrant pain, usually it gets elected or provoked on passive extension
Ex-
of the right hip. If the
And what
patient
is,
is
yeah,
positioned, usually we position the patient on the left side.
exactly. طيب, what is the reason of that? Like we are extending the hip and the patient is feeling pain in the right lower quadrant. What that signifies?
I think it's because of the same thing. It's يعني we're stretching the legs, and with the peritoneal inflammation and with the stretching it causes pain. Maybe I'm not sure صراحة.
Are my slides visible to everyone?
Yes, I think we can see them.
So,
Yes, Dr. Lutfi, I'm sorry for the interruption. We have our second discussant is here. He had some connection problems. So Yusuf is here. So you can alternate between Roda and Yusuf. Yusuf, can you please try using your mic so we know that we can hear you?
Yes, you can hear me now?
Yes,
yeah,
we
I
can.
can hear you, sir.
Yeah. Hello everyone, my name is Yusuf and I am a student in Rakam HSU, year 1 MBS. And I am very glad that we have a meeting with Dr. Lutfi and with Dr. Shadi, and this is a very great meeting and we hope to join all the meeting. Thank
Okay,
you
so
all.
Dr. Lutfi, you can carry on. Sorry for the interruption.
Okay. So, Rauda, this is the special test that we can do in case of acute appendicitis. The ZOAS sign is on the left side and the obturator on the right side. هلا
Yes.
نحن قلنا انه the ZOAS sign is elicited when the patient hyperextend the hip. Okay.
Yes.
What will happen is that the psoas muscle is just posterior to the cecum and the appendix. And in case of retrocecal appendix, when you try to extend the hip, you are stretching the psoas muscle. So
Yes.
this will cause also irritation to the appendix and will cause the pain.
Yeah.
On the other hand, on the right side, the obturator sign, how we are going to elicit an obturator sign.
Usually, what I know is that on usually we ask يعني the hip and the knees are flexed, and then passive internal rotation of the right hip will elicit right lower quadrant pain as well.
Exactly. كمان نفس الفكرة يعني it is the same idea. Obturator muscle is located on in the inner side of the obturator foramen. So it's
Yes.
in the pelvis.
It's
So
just
if the
42
location of the
centimeters.
appendix is pelvic in location and you
Sorry.
stretch the obturator muscle, you will cause this sign to be positive. You will cause the right lower quadrant pain. So these
Yes.
special tests can help you in diagnosing appendicitis and can also help you in identifying the location. If the obturator sign is positive, you'll think maybe the appendix in the pelvis. If the psoas sign is positive, you'll think maybe the appendix is retrocecal.
Yes.
Okay. So, Yusuf, can we start now by discussing the laboratory investigations?
Yes, you can.
Okay. So now if I'm telling you that the WBC is 13.5 with left shift, like there's neutrophilia more than, let's say, 88%, what you are thinking?
This is not the normal range.
Exactly. So there is leukocytosis in the blood and there is also neutrophilia. So it signifies that there is active infection in the body. Now, also another important laboratory data that we can use is the CRP. If the CRP is 88, it means it's elevated. So we have elevation of the inflammatory markers. Okay, in our case, does this goes with acute appendicitis or no?
Yeah, I guess that, yeah.
Exactly. طيب, if I'm telling you that we did a urine analysis, there was no blood per urine. However, there was WBCs, and there wasn't any bacteria. Okay, what are you thinking if I'm telling you that there are WBCs in urine without a bacteria, without blood?
I think there is deficiency in from that side. I think there is something not normal in the urine. I think because there is no bacteria inside the urine.
طيب, if the urine is usually sterile, like there should not be any bacteria if you take a sterile sample, not contaminated sample. But if I'm telling you that there is WBC in the urine, is this goes with acute appendicitis or it goes with UTI, for example?
I think you are the example.
Doctor, can I answer?
Yeah, please.
From what I know is that we can possibly find white blood cells in the urine in appendicitis as well because of the location of the appendix, so it can cause irritation and it can cause mild pyuria or even hematuria.
Exactly. This is important to know that because you should not confuse a UTI with an appendicitis. UTI will have some bacteria in urine and you'll have a positive urine culture. However, in case of appendicitis, because of the location of the appendix in close proximity to the ureter, it can cause some mild elevation in the urine WBC or RBC.
Yes.
So now, based on all the history and physical examination signs and the laboratory investigations, the most likely diagnosis that we are having now is acute appendicitis.
Yes.
Do we all agree?
Yes, I agree.
طيب. Now, what other differentials we should consider in this case? Let's go back to the scenario. So the patient is having right lower quadrant pain. Let's think of it as it is a lower abdominal pain. What other differentials you will think of when you are tackled with this case? Rhoda or Yusuf? Anyone?
It could be, for example, obstruction, or even we can think about a renal colic if it's associated with urinary symptoms.
طيب. Let's think about it in a different way. When I want you to approach a lower abdominal pain, I want you to go anatomically. I will show you something. Look at this picture. When you think of lower abdominal pain, think of the structures that are in the lower abdomen. So what do we have in the lower abdomen?
Okay, we have part of the intestines.
So we have the small bowel.
Yes.
What do we have too? Think,
We can
what
think
are the
about
systems that are in the lower abdomen? We have the GI, but we have also other systems, right?
Yes.
What do we have in the lower abdomen? We have the urogenital system,
Yes, we
the
have the.
urological, yeah.
Mhm.
And in females, we have also the uterus, the fallopian tube, the ovaries.
Yes.
So let's think of first the GI differentials. We have the colon and the small bowel in the lower abdomen. What conditions can cause lower abdominal pain?
We can think
GI,
about.
from GI point of view.
Okay, so other than appendicitis, we can think about Meckel's diverticulus.
Exactly.
Yes.
طب how Meckel's will present?
Um.
It will present with similar picture, like there will be some right lower quadrant pain. There will be some nausea, vomiting. On exam also you will have some tenderness in the lower abdomen. So it will be also difficult to differentiate acute appendicitis from Meckel's diverticulitis. طيب,
Yes.
what other conditions we can also it can also cause lower abdominal pain from GI point of view?
Cecal. Maybe cecal diverticulitis.
Cecal diverticulitis, less common, less when we
Yeah.
think about diverticular disease, where do we usually find the diverticulosis?
On the left side.
On the left side, in the sigmoid. So a sigmoid diverticulitis can cause also lower abdominal pain. That should be one of our differentials. But in case of sigmoid diverticulitis, we have to think that the population will be different than our case. The patient will be more elderly أو يعني old age group. He will have some history of chronic constipation. Maybe he will have some history of painless GI bleed, BR bleed since long time, and now he's coming with acute onset of abdominal pain. شو كمان? Maybe he's having a previous attack of diverticulitis because like the recurrence rate is high and not all diverticulitis are treated surgically. تمام؟
Yes.
You'll think of this way. هلا the typical location is in the left lower quadrant, but if the sigmoid is long and redundant, it can also be extending to the right lower quadrant and give you a similar picture.
Yes.
تمام؟ طيب, this is in case of the colon. طيب, in case of the small bowel, what conditions we can have that will cause a lower abdominal pain? Very common condition. You will find it in children, in adults.
PID or
PID is gynecological, but think of small bowel.
ID. Sorry, لخبط.
A very common condition. It will happen almost to everybody in their life course. Think inflammation of the small bowel. What will happen? Like if I'm giving you a scenario, an 18 years old boy, he came with multiple episodes of vomiting, then he started to have diffuse abdominal pain. He also reports 2 times diarrhea in the past 1 day. And he's having some low-grade fever. He gave history from eating from outside, from cafeteria. He doesn't know its name.
Gastroenteritis.
Exactly. So
Yes.
gastroenteritis is a common differential and it should always be on top of your list.
Yeah.
In this case, طيب, from the history, how can we differentiate gastroenteritis from appendicitis? In case
here
yeah.
the pain يعني how it started and where did it localize later. يعني it started periumbilical and then it localized in the right lower quadrant. This kind of gives me an idea and it's kind of more towards something else other than gastroenteritis.
Exactly.
Yeah.
Another useful thing to know is that in gastroenteritis, usually the vomiting will start first. and then they will develop the abdominal pain. On the contrast, in appendicitis, the abdominal pain will be first, and then they will start developing the vomiting. So it is a good thing, like, to differentiate between them both.
I can't stress that enough. That is the main way that you differentiate. Okay, guys? Gastroenteritis, appendicitis. One, appendix, pain first, then nausea and vomiting. Gastroenteritis, nausea, vomiting first, then pain. Khalas, that's simple and easy.
Okay.
You were asking about the hamburger sign at the beginning. Did you ask them what it was?
Yeah, I was going to ask them when we are going
Here,
to
more of a shawarma sign, but yeah, same thing.
Yeah. So what do you know about the hamburger sign?
It's usually it's I think it's a mass that gives an appearance of the hamburger, like from the name.
No, actually, it's much simpler than that. The hamburger sign, it's elicited on the history. For example, if it like signifies anorexia. Yani if there is a patient, in anorexia is usually the first symptom that will appear in patient with appendicitis, and it has a high sensitivity. Like almost 95% of appendicitis patients will have anorexia. So how you will ask them about anorexia? You will not just ask them, do you have any appetite for food? He might say yes, he might say no. Even if he's a little bit in pain, he will say yes. But if you ask them, like, what do you like for food? Do you like hamburger? You like shawarma? What do you like? If he tells you, like, I like shawarma, you ask him, if I give you now shawarma, will you eat?
Yeah,
If he
so
says no, so
if
this
they
is a positive hamburger sign or
بالضبط.
shawarma sign.
In my defense, there is a radiological sign called the hamburger.
No, but in appendicitis, it's mainly a sign on history.
Yeah.
I think what you're talking about is for in utero for fetal assessment of gender. The hamburger sign. If you have the hamburger sign in the ultrasound, then the fetus is a girl, is a female. So that's what you're thinking of.
Yeah, maybe. يومي بتطار الأكل مخي شوط بس okay.
طيب, what other conditions as an inflammation in the small bowel can cause lower abdominal pain? يعني حكينا عن gastroenteritis, other inflammatory bowel.
Doctor, appendicitis? With appendicitis only or not?
How, Yusuf? I didn't understand you.
I was talking about appendicitis. It's related to the abdominal pain, lower pain.
Exactly. You wasn't there. We were discussing the case, and it is a case of acute appendicitis. So now we are elaborating on other differentials that we have not to mix up with acute appendicitis and how to exclude each one of them. For appendicitis is the case, you are right. But now other differentials, for example, inflammatory bowel disease, especially Crohn's, typically it can present with terminal ileitis. But in case of inflammatory bowel disease, what else will we have on the history that will like direct us to inflammatory bowel disease?
And it's usually recurrent and lasts for several days. They would have, yeah.
They will have some weight loss. They will have some diarrhea, usually bloody.
Yes.
They might have some systemic symptoms, مثلا arthralgia, generalized fatigue. تمام? طيب, this is for the GI. Now we will go through the urological system. What other differentials we should consider on the urological system? Kidneys and ureters.
For example, here, right renal colic.
Renal colic, exactly. Yeah. How renal colic will present?
But usually it would be colicky.
Colicky. Yeah, it will not be continuous. Yes, it will be on and off.
it could be also associated with the hematuria, يعني the patient would report that.
Exactly. So now you mentioned hematuria. Sometimes it can be microscopic hematuria. That's why we are going to proceed with workup for appendicitis, but it's important to say it from now.
Yeah.
Any patient with suspected appendicitis, do a urine analysis. It's a quick test. It's easy to do. It's fast. And if there is no hematuria on the urine analysis, most likely it is not a renal colic or ureteric colic. تمام. Other thing is pyelonephritis. Can
Yeah.
also present with flank pain, high-grade fever, nausea, vomiting. On exam, there will be costovertebral angle tenderness, and there will be some also urinary symptoms. الديسيوريا ممكن blood per urine ممكن
Yes.
in urine analysis we see the WBC cast تمام.
Yes.
But in our case there was no urinary symptoms and there was no flank pain. Well, urine analysis was okay يعني بس mild increase in WBC.
Yeah.
طيب, in females what other differentials we should consider?
Okay, now I can say PID. We can also, it's if she's a female in her reproductive age, it's really important to rule out ectopic pregnancy, especially or pregnancy in general, يعني.
Exactly.
Case of
Exactly.
abdominal pain. We have bad ovarian cysts, or sometimes even endometriosis can present with lower abdominal or right abdominal pain. يعني lower abdominal pain in general.
Ovarian torsion
Torsion,
is
yeah.
important diagnosis also to consider. مثلا في pelvic inflammatory disease we will have some like lower genital symptoms. يعني we might have discharge مثلا motion tenderness on exam, on pelvic exam. تمام. So this is what we have already mentioned.
What about the most common thing that we argue with the gynae about, Lutfi?
ovarian cyst يعني?
Right. Ruptured ovarian cysts.
Ruptured ovarian cyst.
Right. So they present very much like appendicitis. Why? Because when it ruptures, you got blood there. And same as ectopic, when you have blood there, it causes peritonitis. There's peritonitic irritation. And the pain is very similar to appendicitis, but they won't have the anorexia that he was talking about and some of the other specific symptoms.
Yeah.
Okay.
So we have already discussed the differential diagnosis of lower abdominal pain. طيب, what is the pathophysiology of acute appendicitis? Yusuf, can you explain to me how acute appendicitis develop?
All right. First occurs when appendix becomes inflamed. It can be acute or chronic. And the symptoms of that, you can say vomiting, abdominal swelling, or inability to pass gas.
Okay, now we are talking about acute appendicitis. So the simple explanation for the inflammation that will develop is that you are obstructing the lumen of the appendix. And the appendix, as you already know, that it is a blind-ended structure. So if you obstruct the opening of it, anything inside will not go outside.
Stasis,
Okay?
post-stasis.
Exactly. طيب, what will cause this obstruction? Most commonly, a ficolith.
Yes.
This is in adults. In children, ممكن some lymphoid hyperplasia cause this obstruction. تمام? There are other reasons, يعني other uncommon reasons. For example, tumors, seed ingestion can cause that too. Some parasites can obstruct the lumen, but the most common in adult, the ficolith. In children, the lymphoid hyperplasia. طيب, now we obstructed the lumen. What will be inside? Like, this is a bowel. It will be continuously secreting mucus.
Yes.
And this is the colon also. It has some bacteria. So the mucus inside is not going outside. The bacteria are growing, and this will cause increase in the pressure inside. تمام؟
It will spread. It will help in spreading the infection.
Exactly. This will help in the overgrowth of the bacteria and will increase the pressure inside. It will block first of all, it will block the venous drainage of the appendix. The appendix will be congested.
Yes.
And after that, لأنه طبعا الفينس is easy to block. الvein wall is not as the artery wall. It's easy to block. تمام? But then after, with all this congestion from the venous blockage and the increase in the pressure inside the lumen of the appendix, in the end we will have a compromise of the arterial supply. And then we will have wall ischemia and finally perforation. So this is the sequence of the pathophysiology of acute appendicitis. We'll start with obstruction, inflammation, venous congestion, arterial compromise and ischemia, and finally perforation. تمام? So, but what will cause the pain to be shifted from the periumbilical pain to the right lower quadrant? What do you think it will cause this shift of pain?
Usually, what I know is the initial pain is caused by the irritation of the the concept is about يعني peritoneum, الvisceral والparietal peritoneum.
Exactly.
So the initial pain اللي هو periumbilical, I think it's associated with the irritation of the visceral peritoneum, if I remember well. أما after يعني after it localizes, it's caused by the irritation of the parietal peritoneum.
Exactly. Early in the inflammation, there will be distension of the appendix and stretch on the visceral peritoneum. All the abdominal organs are covered with visceral peritoneum, and the abdominal wall is lined from inside with parietal peritoneum. The visceral is supplied by autonomic nerves, sympathetic and parasympathetic. However, the parietal is supplied by somatic nerves from the spinal nerves. The autonomic nerves are not localized. يعني any pain from the cecum, appendix, small bowel, part of the colon, it will be all localized in the same area. The body will not differentiate. The brain will not say, no, this is appendix, this is cecum, this is small bowel. It's based on the embryological origin.
Yeah.
Localized to the epigastric region. Mid-gut, periumbilical, and hind-gut down. بس somatic pain, somatic nerves that come from the spinal nerves that supply the parietal peritoneum, if it gets يعني irritated, it will localize the pain to the area of the irritation. تمام? Early in the course of the inflammation, it will be only just visceral irritation. It will localize to the periumbilical area. But once the parietal peritoneum start to be irritated, the pain will shift to the right lower quadrant to the site of irritation. تمام?
Yes, doctor.
All right.
طيب. Now we took history from the patient. We examined the patient. The next step is we will order some laboratory investigation to complete our assessment. تمام? We ordered CBC. We saw the patient had leukocytosis of 13.5 with neutrophilia. CRP was also high, 88. So this goes with appendicitis, high inflammatory markers, because it's an inflammatory condition. طيب, what other things we have to order? As we already mentioned, urine analysis is very important. It will rule out a lot of important differentials, مثل ureteric stones. And also on urine analysis, we can find some signs of appendicitis, like mild elevation of NWBC without bacteriuria. Beta HCG is very, very, very important in females. All females with lower abdominal pain, they should get beta HCG regardless. Even if she tells you, I'm not pregnant, you should order the test. you'll be surprised of how many females they don't know they are pregnant yet. And you will, if a beta HCG is negative, you immediately ruled out ectopic pregnancy. Tamam? And another reason to order beta HCG, in case of you want to do any further radiological exam, for example, you want to order CT, and the patient doesn't know she is pregnant, and she turned out to be pregnant, and you send her to CT and expose her to radiation without knowing that she's pregnant. So this is a major mistake. So beta HCG for any patient with lower abdominal pain should be ordered. Other tests that you can consider, for example, if the patient comes to you with features of acute appendicitis, but however, he comes with 5 or 6 day history, and he comes also with sepsis, and he's severely dehydrated, you have to order like renal function tests and electrolytes, because the patient might be going also into acute kidney injury and might have some electrolyte imbalance that you should correct. Another thing is, if you suspect that the patient is going through DIC related to the sepsis, you have to also order coagulation profile. تمام؟ طيب. Now the question of the session. We did history, we did physical exam, and we did investigations. And it is our case. History is typical appendicitis. Examination عنا tenderness and the rebound and all the positive physical exam signs. And we have leukocytosis. Can we establish a diagnosis of acute appendicitis based on these findings, or do we need to do any further radiological tests?
I think it's, I'm not sure if it's a clinical diagnosis, but we need imaging for appendicitis. I'm not sure صراحة. If like we need imaging to confirm, or is it like a clinical diagnosis?
طيب. Yusuf, what do you think?
I think we can make further tests if we need. If it's not needed, so okay.
So in this case, do we need to do any further tests or no?
I think no.
Okay. So appendicitis is a clinical diagnosis. If you have the typical history and you have the typical exam and the typical laboratory values, you can take the patient to OR without the need to do any radiological investigation. The radiological investigation will help you if you have an equivocal diagnosis, if you are not sure, is this appendicitis or it's something else. In this case, you can proceed with doing some radiological investigation. However, appendicitis, you should know that it is a clinical diagnosis. تمام? طيب, if let's say it is a different case and we are not sure that this patient has an appendicitis or not, is there any like some clinical scoring system that we can use that will give us an idea this patient has a high probability of appendicitis or no? Do you know any scoring system? Did anyone mention to you before or during your on calls you saw your resident using some scoring system when he tackled a case of appendicitis?
There is, I remember a scoring system, but صراحة I don't remember the details. I think it's the Mantrals, if I'm not, or the Alvarado scores.
Exactly, the Alvarado score. So the Alvarado score will give you like multiple things that you score your patient depending on them, and they will give you a total of 10 points. Like if the patient has less than 4, it's unlikely to be appendicitis. From 5 to 7, there's intermediate possibility, and from 8 to 10, likely to be appendicitis. تمام? You have like let's apply it to our case. The patient عنده nausea and vomiting. This is 1. Anorexia. This is 2. عنده migration of pain. This is 3. This is based on the history. الإكزام عنده right lower quadrant tenderness. تمام، ما عنده rebound. الانفستيجيشن عنده leukocytosis وعنده neutrophilia. تمام. So out of 10 he had 9. So he has a very high probability of appendicitis based on the Alvarado score.
Yes.
تمام. طيب, now let's say in a different scenario, we are not really sure about our diagnosis. He has an Alvarado score maybe of 5 مثلا, and we want to confirm. What can we do to the patient as a radiological investigation to confirm?
Usually as you mentioned before, CT scan is the best like initial imaging modality, except if the female was pregnant. We can also use ultrasound يعني في emergency for يعني a quick.
Hala, let's discuss both ultrasound and CT. CT is better than ultrasound.
Yes.
However, it is like more يعني خلينا نقول more aggressive. You are exposing the patient to radiation.
Yeah.
Ultrasound doesn't have any radiation. So as an initial test, you should go with ultrasound.
Yes, okay.
بس the best test is the CT.
Okay.
Sometimes يعني and it's also يعني مثل patient preference. يعني if you have a pregnant lady, you cannot do for her CT.
Of course, yes.
If you have a child, you cannot do for her or for him a CT. For mainly 2 reasons: because you're exposing him to radiation and there is a risk of developing malignancy later in life. And another thing is that the signs of inflammation on a CT, you'll see some like changes in the fat around the appendix. And this changes will signify that there is inflammation around the appendix.
Yes.
But a child will not have the fat of an adult. So even on a child, it will be difficult to assess appendicitis based on CT. In case of children and pregnant ladies, ultrasound is preferred. In case of adult males or non-pregnant females, CT is the best. But we can also do ultrasound first because we don't want to expose them to radiation.
Yes.
طيب, what are the findings that we'll find on ultrasound in case of acute appendicitis?
Usually the appendix will be distended.
Exactly.
Like the diameter, usually the cutoff number that we use is 6 millimeters.
Exactly.
More than 6. There could be like some shadowing, or because of the edema
What is the description of the appendix that we'll find on ultrasound? It will be a blind-ended tube.
Okay.
This is the normal anatomy, but because of the inflammation and it will be distended, it will be non-compressible. Yeah, it will not contain any air inside. It will be fluid filled. It's non-compressible.
Yes.
تمام. On CT, you'll also find distended appendix more than 6 millimeter with fat stranding. Exactly. In case of complicated appendicitis, you might find some free fluid or abscess formation or phlegmon. يعني a mass, omentum and bowel are all هيك around the appendix. You might find some perforation in the wall of the appendix, مثلا non-enhanced wall, ممكن a pocket of air close to the appendix. This will signify perforation on CT.
Yes, doctor, someone here in the comments also mentioned target sign, which is like an important finding for ultrasound.
Exactly.
when عندنا like rings of hypo and hyperechogenicity في الultrasound.
Exactly. طيب, مثل ما حكينا, if we have typical clinical history, physical and lab values, we can take the patient to appendectomy. We don't need to do any radiological images. However, if we don't have, this is like هيك يعني a simple algorithm. If we don't have the typical and we are like still suspecting other reasons. If the patient is a female, we'll do ultrasound. If it's an adult male, the initial is the ultrasound. However, the most specific and sensitive is the CT. So we can also do CT for adult male patients. In this image, you can see the appendix on the white arrow. You can see that it's distended. It contains no air. تمام, it's fluid filled. The wall is enhanced. معناتها ما في أي perforation أو ischemia to the wall. في عندنا fat stranding بالright iliac fossa. So these are all signs of radiological signs of acute appendicitis on CT. طيب, now we diagnose our patient with acute appendicitis. What we are going to do for him from the ER.
طبعا
تمام.
we'll start طبعا اللي هو supportive care. We'll give the patient IV fluid therapy. If the patient has been vomiting a lot and is dehydrated, it's really important يعني to
Right, the patient exactly.
Yeah. عندنا بعدين IV analgesia is really important, especially if the
Exactly.
patient is in severe pain. We can also give antibiotic therapy.
Exactly.
Yes.
So, as you mentioned, these are our initial management of the patient. The patient can be dehydrated, in severe pain. So we should start him on fluids, hydration, analgesia. We are taking the patient to OR, so the patient should be fasting. We should keep the patient nil by mouth. And we should start antibiotics. As we mentioned in the pathophysiology, it's overgrowth of bacteria. And
Yes.
which type of bacteria that we have in our colon?
Anaerobes usually.
Anaerobes.
And gram negative.
Exactly. So we should start the patient on antibiotics that cover both the anaerobes and the gram negatives. طيب. Then the definitive management is to take the patient to OR and do appendectomy.
Yes.
We have two types, either the open appendectomy or the laparoscopic. طيب. What is the difference between them both? When we أو مو when يعني what is the benefits of laparoscopic over open, or is there any benefit of open over laparoscopic? What do you know about the surgeries? طيب.
Laparoscopic is okay.
Yeah. هلا الاوبن versus laparoscopic as a long term يعني results are almost the same. تمام. Some studies showed that in laparoscopic surgeries they have shorter length of stay in the hospital, less post-operative pain, less rate of wound infection. But the long-term يعني results are almost comparable between them both. تمام. In laparoscopic surgery there is increase in the risk of developing post-operative intra-abdominal collection. تمام.
Okay.
But usually in most of the institutes we do the laparoscopic appendectomy. كمان in addition يعني لل shorter length of stay, post operative pain. كمان it's also for cosmetic reason يعني it's better to have very small 3 incisions, almost 1 centimeter in length, than to have a very long incision in the right iliac fossa. تمام. طيب. Now we start the patient on antibiotics and then we took him to OR. Now we finished our surgery. We found that the appendix is inflamed but it's not perforated. ما في عنا أي مشاكل in the appendix. We remove the appendix and everything is fine. Should we continue the antibiotics or no?
We have to. I think for the antibiotics they have to be there only within 24 hours, and after the surgery we usually discontinue the antibiotics.
Exactly. So now we do source control. We remove the source of the infection. We can continue the antibiotics for 24 hours and that's it. However, if we found intraoperatively that the patient has an مثلا abscess collection أو مثلا كان عنده perforated gangrenous appendix or the patient on presentation was septic, we should continue يعني in complicated cases we can continue antibiotics up to 5 to 7 days. تمام؟ طيب هلا another question does acute appendicitis require emergent surgery؟ يعني هلا أنا I saw a patient in the ER and I diagnosed him with acute appendicitis. Should I take him immediately to the OR or can I wait on him?
If it's not that severe and we want to delay the surgical management, from what I remember is that يعني we can give a trial of اللي هو antibiotics for like 24 hours and then we can delay the surgery. But يعني if it's really severe and we know that it's appendicitis, we should go for the surgery, يعني emergency appendectomy.
لا, I mean now you know your patient has appendicitis. تمام?
Okay.
And you start him on the supportive management and the antibiotics. طيب, this patient, does he need to take him to OR immediately? Or you can take him after 2 hours or 4 hours, or if it's at night, you can take him the next day. يعني, is there a risk of perforation يعني, if you don't take him immediately?
If we confirm the diagnosis, we have to يعني we have to take them for the surgery يعني خلاص as soon as we confirm that it's appendicitis.
Okay, هلا يعني I disagree with you regarding this. Appendicitis is appendectomy is an urgent surgery. It is not an emergent. يعني you have to take the patient to OR but not immediately. فمثلا because why we are taking the patient to OR, we are afraid that he will perforate and all the infection inside the appendix will spread to the abdomen and he will end up with complicated case. تمام? Yes. So our main aim is to prevent perforation. تمام? In the studies, in the literature, the risk of perforation the first 36 hours is very minimal. يعني you have up to 36 hours to to intervene on the patient, and then after that for each 12 hours you have 5% risk of perforation. You can wait on the patient if there is any مثلا any technical thing. If the patient came 3 a.m. in the night and there is no one to operate on the patient, he can wait till the morning till the surgeon come and operate on him. Tamam. So I want to deliver the message. It is not an emergent surgery. If you diagnose appendicitis, you don't have to take him immediately to OR or he will die of sepsis or something, or he will perforate. You can wait on the patient as long as you start your antibiotics. Tamam. طيب.
I have to add, just to add to Dr. Lutfi, to what he's saying. Yes, obviously the management of appendicitis has changed quite a bit over the past couple of decades. You will read in your books, especially the older books, that obviously taken to OR right away. Things have changed quite a bit. Obviously, this is all under the impression that this is early or uncomplicated appendicitis, and there are criteria for uncomplicated appendicitis. And obviously, someone without generalized peritonitis, evidence of perforation, any evidence of systemic or hemodynamic instability. Those are the patients that, yes, okay, you can wait until and allow for the IV antibiotics to take effect, and you can wait overnight. So it's no longer an overnight disease, and a disease where you have to operate in the middle of the night for it, unless they are the criteria that I'm talking about: complicated appendicitis, certain criteria, and hemodynamic instability and generalized peritonitis.
Yeah, exactly. Thank you, Dr. Shadi. طيب, the last question: how should you proceed if you are performing a laparoscopic appendectomy? Like you took the patient to OR and your suspicion is acute appendicitis. For example, you didn't do a CT. You took him on your clinical impression, and then the appendix was normal. Will you remove it or you will keep it?
I think we remove it.
Okay, but why?
I'm not sure صراحة, but I remember in you remove the appendix. I'm not sure exactly why.
خلاص, now you will know the reason.
Okay.
If you go to the OR and you find a normal appendix, first thing you have to look for the other reasons. يعني, if you are doing diagnostic laparoscopy, it will give you very vital information. Maybe if it's a female, maybe she's having ruptured cyst that we couldn't diagnose preoperatively. Maybe there's some tubo-ovarian abscess or inflamed bowel, يعني small bowel inflammation. تمام. So you have to look for other reasons, but you should remove the appendix unless it's contraindicated. لأنه the next time he will develop right lower quadrant pain, they will think of appendix all over again. Okay, so if you remove the appendix, خلاص, you excluded one of the most common diagnoses of right lower quadrant pain.
Okay.
When you should not remove the appendix, imagine that the patient was not previously diagnosed with inflammatory bowel disease, and you go to the OR and you operate because of suspicion of appendicitis, and the appendix is normal, but there is like terminal ileitis, and it involves all the cecum and the base of the appendix. In this picture, you suspect Crohn's disease. And if you remove the appendix, Crohn's disease has a high risk of fistulizing. يعني ممكن يعمل intracutaneous fistula. تمام? So in this scenario, you'll remove the appendix and then post-operatively, you will work up inflammatory bowel disease. You will do colonoscopy. You will take biopsy. Even you will not take biopsy intraoperatively. You will take the biopsy through a colonoscope. تمام?
Okay, yes.
So this is a picture of diagnostic laparoscopy, and we can see the appendix on the left side, how it's inflamed and congested, but it's not gangrenous. So this case can be considered like a simple appendicitis, and we can remove the appendix, and as we said, within 24 hours we can continue the antibiotics, and that's it. We will not continue more than 24 hours. So thank you very much, and I was really honored to have this session with you. If you have any questions, please ask them. And this is the reference that I used to prepare the presentation. I really like this book. It's one of the books that I studied during medical school, and I find it very useful for a medical student to use this because it's at the level and it asks questions, and then it will give you the clinical scenarios, questions, and then answers. So it will be easier to to follow the flow of the scenario. Any questions?
All good from my side. I also am really honored that I've participated in this episode. Wait, Stefan, thank you so much. I don't know if there are any questions from Yusuf's side.
Thank you, Dr. Lutfi and Dr. Shadi, for this participations, and I'm very glad to share with you this session. Thank you, and I don't have any questions.
All right, guys. I think Dr. Lutfi gave us most of the information that you really need to know as medical students regarding appendicitis, and so thank you for that. I'm just going to give you guys a little bit of a different perspective and overview. First of all, just to elaborate a little more on what Dr. Lutfi was talking about, very, very, very important to create your differential diagnosis as you're examining the patient. You guys as medical students, you're going to be seeing a patient and they're going to be talking to you, and as they're talking to you, in your brain, you're already creating that differential in your head. Look at the different quadrants of the abdomen, and based on the different quadrants, think about what anatomy is there, what bowel is there. Okay, so there's this bowel. Okay, so there's Crohn's, diverticulitis, bowel obstruction, hernia, gynae, nephro, blah, 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 blah. All that should be in your head, so that when you're ordering tests, you're not ordering a test and then 2 minutes later you think of, oh crap, I didn't order beta ATG, let's prick her again. Oh crap, I didn't order urinalysis, let's do this again. You know what I mean? So write up your differential and then start ordering your tests. Because trust me, if you don't train your brain to think that way, as residents, you will not be trained to think that way, and you start ordering tests left and right without having an organized train of thought. Another thing is when you're getting a history of a patient, try to create a rapport with them. Try to make them feel at ease. Don't feel like you're interrogating them. The more you create a rapport with them and be friendly with them, the more they're going to divulge information. Next, I want to talk about complicated appendicitis. So when we're talking about complicated appendicitis, we're talking about not the simple appendicitis like the picture that Dr. Lutfi showed us. We're talking about an appendix with an abscess next to it, for example, or what we call a phlegmon. Does anyone know what a phlegmon is from the discussants?
I don't know.
Okay, so a phlegmon is basically an inflammatory mass. It's basically the infection and surrounding inflammation. You know, when an organ is inflamed, it kind of pulls things together into a mass in some occasions. And so when you form the phlegmon, you can actually examine it on exam. You feel a mass in the right lower quadrant. And in those cases, appendectomy is not the right answer, because you go in and everything is fused together into this cement mass. And if you try to excise it, you're going to end up doing a partial colectomy with partial small bowel resection, and you might have to give him a colostomy, and it's a disaster. So you don't want to do that. Phlegmon is not something that you want to operate on. You maybe just put some drains, or not even do anything, just give IV antibiotics until things cool down, and maybe consider an interval appendectomy a few weeks down the line. Another thing is an abscess. So if you have an appendix that's inflamed with an adjacent abscess that is formed, now that means that most likely this appendix was inflamed a week ago, perforated, and that microperforation, instead of causing disseminated peritonitis, caused localized peritonitis and formed an abscess. You understand? So that's why when you have appendicitis, when you have a perforation, you either develop generalized peritonitis because you have free perforation and pus and stool or bacteria is throughout the peritoneal cavity, and therefore you have the hemodynamic instability, the sepsis, and all that, emergency surgery. Or it could be, let's say, in a retrocecal position, or in a location where momentum can get on it and localize that inflammation, and so you develop an abscess. In those cases, you do IR drainage. So interventional radiology places a drain into the abscess, drains it, you treat the patient with IV antibiotics, and then as an outpatient, you see them in clinic and discuss an interval appendectomy after that. So early uncomplicated appendicitis is mildly inflamed, some fat stranding on the CT or ultrasound, no perforation, no free air, no generalized peritonitis. Those patients nowadays, especially in the era of COVID, we've been, you could say, experimenting a little more with the concept of non-operative management of appendicitis. Sorry, excuse me for 1 second. Dr. Shadi here? Hi, dear. Good. Okay. Uh-huh. Right. I know. You want to transfer him to the floor? Okay. His oxygen requirements are tapering down? Okay. Can you please just call Dr. Hajar and sign out to her? Hajar, yeah, she's a specialist on call. She's a specialist on call. Just sign out to her and let her know that you're going to transfer the patient. I don't mind. All right? Thank you. Sorry about that. With the era of COVID, we're really starting to experiment with this non-operative management, meaning IV antibiotics, wait 24 hours, see if the patient improves, and if they do, they might not really need appendectomy. Now listen, you guys are all medical students, which means for your exams, for your books, the standard of care is still appendectomy, okay? I'm not saying this so that you guys can go answer non-operative management for any of your exams. It's still, appendectomy is the gold standard for management of appendicitis. I'm just saying the two main reasons not to operate are phlegmon and abscess, okay? In those cases, you deal with the inflammation and the abscess until you do an interval appendectomy in the future, usually 6 weeks later. And in certain cases, like a critically ill patient that can't handle surgery, or COVID positive patients in these days, or like I said, there are trials now for non-operative management. There's something called shared decision making, where the surgeon discusses with the patient the pros and cons of not operating. And believe it or not, if you guys want to know the data, the most recent meta-analysis showed that there's a 91% success of non-operative management of appendicitis with just IV antibiotics and NPO for a couple of days in early uncomplicated appendicitis. 91%. So that's huge. But there's around a 30% recurrence with complicated appendicitis within 1 year. So that's why it's a decision that you have to have with the patient. Yes, they're going to have less pain, less disability, better quality of life if they do non-operative management, but they run the risk of recurrence of the problem, and maybe with next time complicated appendicitis and further disability down the line.
So is the non-operative management practiced يعني commonly الحين ولا we usually go with the standard?
It's starting to pick up ground actually. In the States, it started. It's not gold standard yet. In Europe, it's a lot more common than the States. So the States is still mainly appendectomy for all appendicitis. In Europe, it's starting to become more practiced. Here in the Emirates, it was always appendectomy until the COVID crisis started, in which case we started trying this conservative management so as not to overload our OR resources. And a lot of patients have been getting away with not operating on them. Again, early, uncomplicated appendicitis. But let me say it again. For your exams, it's still gold standard appendectomy.
Okay.
Any questions, guys?
Not from my side.
Thank you so much for inviting me, guys. I appreciate it.
Thank you, Dr. Shadi and Dr. Lutfi. So, guys, any questions from the floor? All right, then I guess we're good to go. Thank you, Dr. Shadi. Really appreciate it. Dr. Lutfi, you've done a great job, honestly. Thank you so much. And inshallah, we'll see you in next episodes. Thank you. And thank you for our discussants, Roda and Yusuf, and our attendees. So see you guys.
Take care.